At sa ulo ng mga nagbabagang balita, heavy metal poisoning.
Heavy metals such as lead, mercury, and manganese have been known for many years to produce toxic effects on the central nervous system. Their presence in the environment and at working places may pose serious health problems. In addition, there is occupational exposure of workers to lead in at least 110 occupations. Mercury compounds and elemental mercury are converted to methyl form by microorganisms, and this also are released from fungicides. This methyl mercury pervades the biosphere and displays extraordinary affinity for the central nervous system. Careful psychological testing is essential to disclose impairment due to exposure to mercury in workers. Mercury exists in several forms. This includes metallic or elemental mercury, mercury salts, and organic mercury. Metallic mercury is used in the extraction of gold and silver from ore, in dental amalgams, and in a variety of technical equipment. Mercuric salts are used in some antiseptics and stool fixatives, and formerly were used as diuretics. Organomercurials have been used as fungicides and antiseptics. Methyl mercury and other organomercurials may accumulate in sea life after environmental contamination. The mechanism of toxicity of mercury involves the reaction of mercury with sulfhydryl groups, binding to proteins, and inactivating enzymes. The nervous system is particularly sensitive. Metallic mercury vapor is well absorbed in the central nervous system and is also a pulmonary irritant. Inorganic mercurial salts are highly corrosive to the skin, eyes, and gastrointestinal tract and are also nephrotoxic. Organomercurial compounds are toxic to the central nervous system, and methyl mercury is teratogenic. For the toxic dose of metallic mercury, the OSHA workplace permissible exposure limit is 0.05 mg per meter cube as an 8-hour time weighted average. The air level considered immediately dangerous to life or health is 28 mg per meter cube. For inorganic mercurial salts, the acute lethal oral dose of mercury chloride is approximately 1 gram. For organic mercury compounds, which have variable absorption, the daily safe limit for ingestion of methyl mercury contaminated fish is 0.03 milligrams. The clinical presentation of mercury involves an acute inhalation of high concentrations of metallic mercury vapor, which may cause severe chemical pneumonitis and non-cardiogenic pulmonary edema. The acute ingestion of inorganic mercuric salts causes vomiting, diarrhea, and shock. Renal failure may present within 24 hours and heralded by proteinuria and hematuria. Hepatitis may also occur. For the chronic inorganic mercury poisoning, it causes permanent central nervous system toxicity, which includes irritability, memory loss, shyness, depression, insomnia, and tremor. For the diagnosis, with acute metallic mercury inhalation, chest x-ray, and arterial blood gases may reveal early signs of toxicity. After ingestion of inorganic mercuric salts, pronounced vomiting and diarrhea are so common that the absence of severe gastroenteritis makes serious intoxication unlikely. For the specific levels of mercury, one should obtain blood and urine for mercury levels. Collection of 24-hour urine mercury is useful in determining body burden. In acute situations, a spot collection may be diagnostic. Normal whole blood mercury levels are usually below 10 microgram per deciliter, and normal urine levels are below 50 microgram per liter. For the treatment of mercury intoxication, after inhalation of metallic mercury vapor, give supplemental oxygen and observe closely for several hours for development of acute pneumonitis and pulmonary edema. After mercuric salt ingestion, anticipate severe gastroenteritis and treat shock aggressively with intravenous fluid replacement. Treat renal failures supportively. Provide symptomatic supportive care after organic mercury ingestion. The specific drugs and antidotes for mercurial poisoning includes the provision of inorganic dimercaprol for systemic intoxication, especially in patients with inorganic mercury salt ingestion. Dimercaprol is given 3 to 5 mg per kilogram intramuscularly every 6 hours. Oral penicillamine is also an effective chelator. Follow blood and urine mercury levels and stop chelation when urine mercury levels are below 50 microgram per liter. Unfortunately, chelation therapy is of no apparent benefit for established neurologic toxicity.
The following is the management of mercury toxicity.
Lead has many sources of exposure. For children, it is mostly ingested. It could come from house dust or paint chips with lead salts. In adults, it is mostly from inhalation. From welding, battery factories, radiator repair shops, metal smelting, heat stripping or sanding paint from old houses. Its mechanism of toxicity affects organs like kidney, nervous, reproductive, and hematopoietic systems by displacing other metals from normal binding sites to produce some of its biochemical effects. In addition, it binds to sulfhydryl groups and disrupts cellular function. The toxic dose for ingestion of lead is greater than 0.5 milligrams per deciliter, which is absorbed for several days. For inhalation, the exposure limit for airborne elemental lead fumes of inorganic lead compounds is 0.05 mg per meters cube. For organic lead, it is 0.075 mg per meters cube. The clinical presentation for the acute ingestion of lead is abdominal pain, vomiting, and diarrhea. For chronic intoxication, abdominal colic, constipation, anorexia, headache, irritability, and fatigue can persist. Encephalopathy is also a common presentation of lead intoxication. The diagnosis of lead usually requires X-rays that may reveal radioplaque flecks of paint and X-rays of the long bones that may demonstrate lead lines in children. For the treatment, children with delirium or encephalopathy should be monitored closely and treat seizures and coma if they occur. Overhydration should also be avoided.
The following is a summary for the management of lead toxicity. There are many sources of exposure of manganese. It can be from mining, metalworking, foundries, or welding. Its mechanism of toxicity is enzymatic inhibition, leading to neurotransmitter imbalance in the central nervous system. The toxic dose, when inhaled, is less than 5 milligrams per meters cube, and the air level should be less than 10,000 parts per million. Its clinical presentation can either be acute or chronic. In the acute type of the clinical presentation, it can cause irritant-type pneumonitis and metal fume fever. For the chronic type clinical presentation, it can be either psychiatric disorder, neurologic toxicity, or extrapyramidal movement disorder. Diagnosis consists of testing the whole blood, serum, or urine. The arterial blood gas and chest X-rays are also useful. The treatment for acute manganese toxicity is to administer supplemental oxygen, treat bronchospasm and non-cardiac pulmonary edema if they occur. Otherwise, if it was chronic toxicity, you should treat the psychiatric and neurologic effects with drugs. The following is a summary of management for manganese toxicity.